All right. Good morning, everyone, and welcome to the second session of our Healthcare Global Track. Today, we will dive into the challenges of supporting and delivering healthcare solution and knowledge in emerging markets. To help us with that, we are joined today by Professor Prashant, Head of Affordable Medical Technologies at King's College London, Dr. Gaya Gamhewage, Head of Learning and Capacity Development at the World Health Organization, and Andrew Storey, Senior Director at the Clinton Health Access Initiative. Prashant, Gaya, Andrew, how are you doing today?
Good, thank you.
Really happy to be here, thank you.
All right, so I will let you introduce yourself in just a few minutes. Before getting us going, let me just remind you of the structure of this session. So first, so each one of our panelists will present their work. Then we have about half an hour of like a moderated discussion, Q&A with the audience. And finally, each of our panelists will be put in breakout rooms where you will have the possibility to directly talk to them without that session being recorded or having a moderator between you. All right, so let's get started. Prashant, can you share your screen?
Absolutely.
Perfect.
So before I start, let me do the tech check to ensure everything is working as expected.
Seems to be working.
Could you confirm that you can see my screen?
Yes, we can.
Okay, lovely. Hello, everyone, and thank you for having me here. So I come from India, so hence I'm starting with Namaste, which actually means I sort of pray to the divinity in you, which I strongly believe which is needed to bring healthcare to everyone in the world. I had a portfolio career and training, and I work at a lot of places, but I'm currently the head of affordable medical technologies at King's College London. And I trained in multiple ways as a physician, as an engineer, as a designer, as an entrepreneur, and found my joy in teaching young people to innovate for global south and then bringing it to the global north. Working at so many places gives you different boss, but I think I always show this picture and say that my boss, and for anyone working in healthcare, our boss remains the poorest of the poor for whom we work. And whatever we do, we need to ensure that the boss remains happy. This is my sort of personal statement. I framed it for myself a few years ago, that in 10 years, I aspire to touch 10 million lives. Not very close to 10, but I think I've crossed the first 1 million, which is quite difficult. And this is something I presented at a few forums, even at a tech forum in WHO, and people liked it. So I thought I'll use it again to bring in the narrative. When you use standard economics to talk about countries, we kind of like to classify the world as developing, developed, and underdeveloped. But I was in this room full of people. I think more than 100 countries were represented in Geneva. And I asked them a question that, do you have enough resources to deal with healthcare in your country? And not a single hand went up, which means when you look at health economics, no matter where you come from, everyone is resource constrained. And that was quite nice. And hence, there is a value in frugal innovations or affordable technology development for everyone, because everyone is poor in their own way. And hence the philosophy of frugal innovations, which is more value from less resources for more people. To do this, my approach has been to connect the right people to create innovations and change by deploying it, which I've primarily done as an entrepreneur inside academia, working in different universities and creating student-led enterprises. And set up a lot of programs around the world. I need to connect two more dots because this is a bit sort of outdated diagram, one in South Africa and one in Brazil. And I'll today talk about who did all this. I'm not one who should be taking the claim for all the positive outcomes. It's a very bright set of people brought from different backgrounds, which was the key, because for very long It's just either the doctors who had an opinion on how medicine should be done, and it's only engineers who had an opinion on how to engineer products. And there are more people who need to get involved. And I use the word constrained conversations because it is my biggest challenge in my career has been to get these people in a room and talk the same language, because it's really, really, really difficult. Just photographs of some of my students. There are much more. If I put all of them, probably it will become pixel size with more than 300 people trained so far. And a quick snapshot of how we went about it. So I created a curriculum, a program, borrowed and adapted and adopted from business schools, from design consultancies, from product development firms, and I call it the 5D program. Essentially, very simple, very intuitive. Discover an unmet clinical need, define the constraints within which you must fix the problem, co-design solutions with stakeholders, develop the product to the point of commercialization, and the 5th D is deployment, and I'll show you some examples. But before I do that, discovery starts from putting people inside the setting, not in front of a computer where they come up with publications and frame a research question, but frame the problem using first-hand experiences. So my students spend a lot of time in the rural clinics, in the ICUs, here and there and everywhere, every aspect in different parts of the world in healthcare systems. What it does is makes them fall in love with problems, which I think is the most important thing. They do not quit, even when going gets tough. Even when there is no funding, they don't hop from one project to another. They say, I saw a person dying, I need to fix this. That's the purpose of my life. Then just love is not enough. So then we say, let's define the problem and bring in some objectivity, which I define as finding a problem among the many that they see, for which even an imperfect solution will sell. And sell, I do focus a bit on selling part, because economic viability, I believe, is very important for anything to succeed and reach the end beneficiary. Not saying profitability, but viability, and both are very, very different things. And in doing all this, we use a time-tested design tool called journey mapping, where we look at people, how they become patients, how they exit the system, remain in the system, get cured, or unfortunately die. And wherever there is a friction point for a patient, and we try to fix that. And finally, the last bit is the design bit, which is the fun phase, where we use extremely affordable methods of design. Yes, we have 3D printers, but I personally prefer to use clay, because it can take a shape very quickly and it costs 10p rather than one whole night and 30 pounds or 50 pounds worth of resource to print something small. Which means we teach them to be resourceful rather than be ready and be prepared for an environment which is resourceful. In doing this at King's, we have set up an alliance, which is called the Affordable Health Engineering, Entrepreneurship and Design Alliance, where we share wisdom among different partners, which are hospitals, universities, not-for-profit organizations, design studios, among others. And just I'm trying to show some of the people who I have worked with and learned a lot from them, working with them around the world in different parts. Coming to the 5th D, which is the deploy. Some of the products which people have built, and I think because it's limited to 10 minutes, I will try to talk of, say, 2 of them. So, for example, Consure Medical on the right is a very simple device, which is a better way to manage fecal incontinence in non-ambulatory patients. In plain English, when someone can't poop by going to the loo, but has to do that on a bed, you would be surprised that it's a very depressing moment for them. In fact, the patients say that, the first comment that we heard was, well, you have a pipe to connect us to a bag where I can pee, but why is it so clumsy? Why is it so yucky? Why is it so smelly for us to poop in a diaper or a pan or a bedpan, because I can't get out of the bed? Can't there be a tube for that? And this was designed out of that user complaint. And that's one example. The second one, for example, is here, which is a fetal-maternal monitoring tool, something without which you cannot imagine modern obstetrics and maternal health, where a product which was invented somewhere around the Second World War has not changed in the 55 years. It has become better, but it has not changed in shape, form, and usability. A 10-kilogram device, which when a company sells, they also sell a table along with it, as you see here. They sell supplies of thermal paper to print and requires AC power, a luxury in many parts of the world. 2 probes, costs roughly $5,000 US, and a constant feature across every device. I'm not trying to pick up only on one product. I'm picking up, and I'll tell you the reason. But the constant problem around everyone is that you will see the obstetric nurse telling the pregnant mother, don't move. Because if you move, this will cause a reading. This will cause an error in the graph. We invented a better one, 150 grams, charges using any mobile phone charger. Once charged, runs for 48 hours. Just one probe, no wires. Mother is free to move. And we removed the zero from the price of the product. We insisted on not putting a smiling face because women do not smile during labor. I've been telling this to marketing departments of multiple organizations, but they don't seem to agree. They don't remove that. Essentially, when we are designing for the poor, designing products for the poor, we do not need to poorly design them. They can be elegant, functional, and above all, they can meet all the quality standards. So all the products that I showed you and those that are in the pipeline are all built in ISO 13485 certified organizations, which my students have created. And depending on which geography they commercialize, they are CE certified and USFDA approved. A quick snapshot of people I have trained and things they have achieved. This is something that has again been adapted from a few presentations by people in this field. And I really like it because it captures the journey when you try to solve a problem. You can fall in a valley, a ravine, or a canyon. And some of them come out, some of them don't. And those who do get the star point over there with commercialization. And I think people after me are going to talk about these, I think specifically around the regulatory clearance, VC funding, manufacturing and commercial launch, and then hand-holding them to get through government orders, which is really, really tough. People at times think that to invent is the toughest part. I like to reiterate that's just a valley. You have ravines and canyons after that. In short, I have learned that it can be taught that you can innovate. You don't need to be a born innovator. You can be taught to innovate. And at the end of the training comes this change in mindset that people start looking at problems as opportunities. And when faced with a challenge, they don't complain, but they then take an initiative to change. And I would say my real products have been the people which I can be happy they have been reinvented during this journey. And I think in these times, no presentation can end without talking a bit about coronavirus. So we use the same this, and we worked on 2 ventilators UK in response to the government challenge, which was called Oxvent, a very large team. And the second one is BVent with Indian Institute of Science Education and Research, Pune. And the second one in particular has a price of £100. And it was a modest failure. Because what we realized is that in the initial days after the ventilator rush, we were very happy that this product did not need to be used at a scale that we wanted. But we are still proud that this has found a new market in anesthesia for snake bites, among other things. And this is probably the first in ventilator with no electronics. It has not even a capacitor. It's purely mechanical and can be put together in a garage. So I think I have exhausted my quota of time, and that brings me to the end of my slide. Thank you, and I look forward to talking and discussing with my colleagues.
Thank you, Prashant. That was a very inspiring presentation. I love your take on medical device development. We already talked about that, but yeah, it's a really different take from what we used to here in business school. So thank you very much for that. Gaya, do you want to present next? Can you share your screen?
Sure. Thank you so much. So it's going to be a hard act to follow because if your audience isn't aware of medical devices, you might be even less familiar with what I'm going to talk about. I'm not an entrepreneur. I'm not an engineer. I'm not a designer. I'm just a doctor. And I've worked with the World Health Organization for 20 years, My education went along public health, international policy, and so on. Currently, I lead all of the capacity development and learning for our health emergencies program. So I don't know how much you know about WHO, but the health emergencies program is a very big part of it. And of course, because of the pandemic, more people are aware of some of the things we do. But I wanted to take the next 10 minutes to really just focus on, what is the future of health emergency management and how we need to innovate, not just products, but partnerships, platforms, thinking to ensure equity, access, and create agency in people to protect their own health. So this is where I thought I could bring some value. This is the frame in which we work. The Sustainable Development Goals is the global political agenda for health and for all of the development issues. So it is addressing economy, it's addressing health, it's addressing climate, it's addressing people working together. And we set these, and it wasn't WHO or UN agency, it was heads of countries. They came together and they said by 2030, we will achieve all of this. And the Sustainable Development Goal 3 on good health and well-being is the one that obviously we focus on, but you cannot achieve SDG 3 without addressing all of the other things. As the previous speaker said, poverty influences health more than anything else, access to technology, jobs, environment. So now this is the good news that we agree on what we should do. The bad news is, even before the COVID pandemic, only 5% of countries on this planet were on track, on target to meet SDG 3. Now, after the pandemic, I would quite confidently say no country is going to meet these targets. And this is where innovation really has a role to play. Now, within WHO, we try to focus in on that a little bit. And what we've promised is in the next couple of years, we would have supported, helped 3 billion people. So 1 billion people more benefiting from universal health coverage. 1 billion more people enjoying better health and well-being, and 1 billion more protected from health emergencies. And it's in that health emergencies domain that I work, and in fact, some of my colleagues are also on the call. The previous speaker talked about, all countries are poor when it comes to health. And it is true. No country, including the richest countries in the world, have been able to give universal health coverage. Now, I'll just give you a little bit of economics and financial data. So what is the cost of giving everybody healthcare, and what is the benefit? Investments in health systems, not just hospitals, but whole health systems, could prevent, by 2030, which is only a few years away, 97 million premature deaths. Okay, so we could save that many lives. What will it cost? It will cost increasing investments over the next decade or so to about 371 billion. This is actually nothing because the pandemic has cost us 11 trillion so far, and it will cost 11 trillion more in loss of jobs. So really, what is the price tag? It is the SDG health price tag is 300 is this little, but actually it works out to $58 per person per year. Now, this is not a lot, even in the emerging economies you talk about, and even in poorer countries. I come from Sri Lanka. We are neighboring India, and you can see we were a low-income country, but a policy of free health and free education has completely transformed society, economy, health, and so on. Now, investing $58 per person per year could increase life expectancy by 8.4 years. Right? And life expectancy is an indicator that we use to look at the robustness of health services in a country. Prashant talked about how Indians say hello. So Sri Lankans say hello by saying Ayubowan. And Ayubowan means, may you have years added to your life. So even from ancient cultures, we understand the importance of life expectancy as an indicator. Now, this slide, I would have to explain this slide a lot before the pandemic, but I think now with the pandemic, most people can understand in a glance. This is a picture taken, I think, 2016. This is just global air travel, passenger travel in one day in 2016, right? Now, what does it say? A pathogen from one part of the world can be in another part of the world very quickly because of the way we travel, we trade, the volume of it, the complexity of it. For the first time in human history, more people live in crowded urban settings than they do in rural settings, right? And we've seen the devastating effect of the pandemic in crowded settings. You've seen in the country that invests most per capita in health is the United States. You see even there where the mortality was, where people died. They were from African American communities, they were poor. So it's a very clear picture of how environment affects us. Poverty, lack of access to education, employment, but also because of the way we are running our economies, deforestation, environmental degradation, climate change, the way we do agriculture, livestock farming, and misuse of antibiotics. You know that 70% of antibiotics produced for humans are used in livestock, in animals. So with this, we are creating the emergence of new pathogens, including viruses like the one that caused this pandemic. And they circulate so much and they come into contact with us. And they are novel viruses. We haven't been exposed before. So that's how a pandemic starts. Lack of access to health services. If you talk about, I think, 90 million people in Syria, Yemen, Afghanistan, all of these places for more than 10 years at a time without access to health services. Surveillance, early warning is really poor at the moment. And also technological and innovative advances. People can now synthesize dangerous pathogens in their garage, not just that life-saving oxygen equipment that Prashant was talking about. And of course, our beliefs, traditions, and practices, we have certain social beliefs that really help pandemics explode. And of course, political and social factors. Today, 1 billion people have been vaccinated against COVID. 1 in 4 people in rich countries like where I live in Switzerland have had a vaccine, but only 1 in 500 in poor countries, right? Less than 0.2%, less than 1% of these vaccines have gone to low-income countries. So we have a really big problem, not just because of inequity, but in poorer countries where the virus is circulating really fast, they have more opportunity to mutate and come up with strains that are different. So there are lots of things going on in the world. So WHO's role, we have many roles in health, but in emergencies, we lead and coordinate the international health response, particularly for outbreaks, disease outbreaks, epidemics, pandemics. And everybody's seen pictures of COVID. And I wanted to share this picture with you. This is from my experience in West Africa, Ebola 2016. And this is how we fight pandemics. People who come for response terrify the communities. They look like aliens. Here they're removing a boy who's dead from Ebola. Now, if I'm the mother sitting in my house here and seeing somebody else's child being taken away, of course, I'm not going to report that my child is sick. I'm not going to go to a treatment center. So really, although we have technology, we have vaccines, treatments, we know how to do things, we deploy equipment and we innovate, we are not addressing the social, cultural aspects that really move this forward. So, we assess global risks. I think in a day now we get like 26 million signals that we are assessing. It's an incredible number. We have to constantly see what's going on in the world. We develop strategies, and of course we respond. So I won't talk about the 50 other emergencies that we are responding to, which is what we're doing today. I'll just talk about COVID and some of the things that we have done. We've brought together all the UN 23 agencies to coordinate response across the world. Since the beginning, we've developed and distributed more than 500 technical guidance. That's WHO's core job, to look at evidence and develop guidance. We've deployed more than 200 emergency medical teams and a global outbreak alert response network. We've shipped 250 million PPEs, including masks and gowns, and health workers were expected to work without this. We have been working directly in about 150 country offices, and you can see all of these things we've done. And the respirators, we ourselves have shipped 20 million. And now I know there's a big dearth of respirators in India at the moment as well. But here you'll see that we actually deployed knowledge in usable forms by focusing on learning and training at the front line. And I'm very happy, you know, my colleagues, Hey Newton and others are on the call. They actually, not me, I lead the team, but they actually took these guidelines, more than 500, and transformed them into courses on our free platform. And I just want to take a few minutes just to talk you through that, because for us, this is an innovation. WHO guidelines used to take about 5 to 10 years before it reached the front line. But we innovated and we had this ready before the pandemic. It's free, anybody can access it, and we've done things to make accessibility even more so. So you can do self-paced courses. We are also doing interactive courses, and what we've done is we've made it free. We've made it low bandwidth, and if you can actually download it onto your app and use it offline. And we've really pioneered this charge towards making knowledge available in local languages, so that frontline responders communities. And because my colleague is originally from India, actually my team worked with volunteers in India to develop the first sign language course as well on COVID. And we have something like 18 million community that our collaborators are working with. So really, what did we learn? We learned 4 things. The first thing is equity matters. It has to be the founding principle. Without equity, it's not just our values are challenged, it's that our health and survival are challenged, right? And really, without equity in access to training, education, knowledge, you cannot have health equity. The second is access. And what we do is we remove language barriers, digital access barriers, cost, but also gender and social norms. 70% of the global social care and healthcare workforce are women. Women are usually in unpaid, low paid, underpaid jobs, right? They don't have access to training. So usually men are only 25% of health leadership is women. So usually somebody else is in charge. So, and if you take Africa, about 48% of the world is online, but only 33% of men in Africa online, and only 20% of African women are online. So you can see the layers of inequity growing. Solidarity is not just a word. And governments like India have donated 40% of their vaccine stocks to other countries. For example, Sri Lanka received its only vaccines from India, right? But rich countries still have 3 times, 5 times the vaccines they need. So, we have to operationalize this through policy, through processes, through partnerships, through people, through platform, for knowledge, operations, and funding. And most importantly, as Prashant said, people are at the center of this, but it's not enough just to see people at the center of this or feel for them. We have to empower them. So we have to use knowledge, education, and systems to make sure people can access the know-how, the knowledge they need to protect their health and the health of others around them. I'm going to share this presentation, so I'm not going to go through it in detail, but I leave it because you can use it and you can get on this platform. Just for COVID, we've got 32 courses. We've got people from across WHO contributing. We have a lot of channels. It's really interesting. So this is the summary: 5.3 million people, 32 COVID courses, 52 language. And we have translated nearly 9 million words. And this has been done not by paying for services only. Lots of volunteers, co-creation, crowdsourcing, a lot of innovation in the processes that we talked about. I'm sure you've heard about the UN and how stiff and boring and bureaucratic it is. So I want you to know that not all of it is like that. And of course, we have other topics as well. So I leave all of this. You can see how we've grown. Our first course came out thanks to my team, even before we declared a public health event of international concern. Because as public health experts, we know when there's a novel virus, it's going to spread, right? So this is how we've grown. It's been amazing. We have more users than some of the biggest commercial platforms worldwide by a factor of 3 at the moment. And you can see it's very strategic. These are the pillars of the global strategy, and these are the courses we have. And I leave this because this is actually an interactive slide where you can, if you want to do how to do clinical care in Vietnamese, you can just click here and go to the course. So my colleagues have done this for you. You can use it. You can see how we've crowdsourced to get all these translation. And of course, we've won lots of nice prizes, and we feel very proud of it. And of course, it's very important to create the body of knowledge. So we publish a lot as well. So I think that's the start. I wanted to just use this example. There's a lot we could talk about, and I hope you found at least some of this interesting. Over to you.
Thank you very much, Gaya. That was a very fascinating presentation and very timely as well. It's great to, see firsthand the work the WHO has been putting, especially with all that training you've just discussed and all the translation it goes into. We don't necessarily think of that, but I guess that's something we can delve into more, a bit more during the Q&A. Andrew, do you want to share your screen now?
Yeah, hi everyone. Let me just share my screen. Cool. Can you see that? Is that great stuff? Well, first of all, thank you very much. Thanks for inviting me for this, and thanks for those 2 excellent presentations. If I can start off perhaps by echoing Dr. Gaya. I'm also not an entrepreneur. I'm not an engineer like Professor Prashant. I'm not even a doctor. I've been at CHAI for the last 10 years. Prior to that, I was a management consultant. I did my MBA at Cornell University, and I still see myself, even though I've been at CHAI for so long, as a management consultant. I see CHAI as basically a management consultant agency working within a very distinct area, which is the field of global public health. If I can kind of position CHAI as an organization, we're further down the value chain from where Dr. Prashant described earlier. So we don't innovate, we don't create new products, anything like that at all. What we're about is actually addressing that access barrier. And the clue's in the name, Clinton Health Access Initiative. We're trying to understand why a product, a new product that's being developed, and perhaps is the WHO recommended product, the product that's the optimal treatment or piece of equipment, the product that you and I would get if we went to hospital right now for some condition. Why that isn't available in so many LMICs, lower middle income countries. Why instead products are often stocked out, or maybe a subpar quality version is provided instead. And so what I'm going to talk about today is 2 examples, one historical, one more recent, of trying to address that access barrier, trying to make these products available in countries and to do so in a sustainable fashion. So let's move on to a couple of slides. So first one is historical. It's about ARVs, which are the drugs used to treat HIV/AIDS. And this is where CHAI came from. Originally our name was the Clinton HIV/AIDS Initiative, focusing just on HIV and AIDS. And over time we've evolved into a wider array, a greater area of public health. But we're looking at HIV, ARVs, when we first started back in 2002, 2003, and we were in a world, all of us were operating in a world, where the vast majority of people living with HIV/AIDS were in low middle income countries. 92% of people here. It was even worse for pediatric patients, for children in the West, simply due to the success of elimination of mother-to-child transmission. The market for pediatric drugs, for ARVs, was extremely low. From a pharmaceutical perspective, there was no money to be made there. There was no one to sell these products to. In lower income countries, of course, unfortunately, the situation was very, very different. And yet the cost of ARVs was just ridiculously high. You see on the slide again, $680 to $12,000 per person per year. These are unaffordable. And conventional wisdom, if I can say it this way, was simply this was just something that could not be addressed. This was just a sad and tragic state of affairs. Each country was procuring ARVs independently, where they were procuring at all. in a very poorly coordinated fashion. Chai and partners moved into this mix and said, okay, what can we do to try to address these supply and demand constraints? We worked through creating a procurement consortium and volume guarantees, where we're saying to pharmaceutical agencies and companies, look, we're not just advocating for you to lower your price. We understand that you're not running a charity, you are an organization who needs to make profits, but how can you do that in terms of reducing your prices and increasing your volumes as a consequence? So we looked to basically increase market information, ensure that these manufacturers, suppliers started to have surety, guarantees that if they procured a certain volume of drugs, that they would be bought. And because they had that assurance, because they could plan accordingly and run batch production and so forth, suddenly now a situation where they could manufacture drugs for a much lower cost and sell the drugs for a much lower price as well. We worked with governments to identify the best optimal treatments, worked with governments, we're now working in more than 40 partner countries with their forecasting and quantification needs, so they knew exactly how much of each drug they should be procuring, working to ensure that they were, and then supporting them to track product uptake and adoption. And that gets into the situation today, if I can skip to a slide, where the market itself for ARVs has increased dramatically. So again, from a supplier's perspective, this is a win. But more importantly, from a user perspective, from a patient perspective, these drugs became a lot more affordable, and the number of people who are now successfully on the recommended, the optimal form of treatment has increased dramatically. This graph on the right, I think, best illustrates that, where you have the number of patients, well, I don't go through the numbers, but you can see a dramatic price reductions and a dramatic increase in numbers of people on ARVs. And that continues today, with more work being done in this area. And again, focusing on that access side, that access issue, to ensure that HIV treatment is made well available. But like I said before, we as an organization have moved into other areas since, because understanding that global public health in many ways is like a tapestry. When you start pulling this thread, there's so much more that comes out of it. So you might well say to me, okay, treatment for HIV is great, but how are you stopping, what about the diagnostic side? What about the screening side? What about actually preventative measures as well? And of course, this moves into a whole different host of different points. I'm going to talk to you quick look at how CHI actually works. We work at a global level. We have a global team, which I'm a member, and then we have in-country implementation work as well. We operate in a large number of countries. I think we have 28 active country teams working across sub-Saharan Africa and parts of Asia, where we're supporting the ministry on the ground in terms of their strategic planning and implementation. Let me talk to you about one more project, another project, a more recent project that's very close to my heart, and that is related to congenital syphilis. More specifically, it's about stillbirths. Around 11% of stillbirths in sub-Saharan Africa are caused by congenital syphilis. And syphilis is one of those things I'm sure everyone on this call is well aware of. Everyone knows what syphilis is. And yet, it's also very easy to treat. A form of penicillin, which has been around since the 1940s and costs, I don't know, $1 or so, but very, very small amount of money, widely manufactured off patent, would be sufficient to prevent nearly 350,000 adverse birth outcomes each year, which are caused by simply a pregnant mother, having syphilis and not being treated during her pregnancy. Say 11% of stillbirths in sub-Saharan Africa being caused by this one infection. This one infection, I say, is very easy to treat, and a burden that is there's clumped across a relatively small number of countries. And again, as you see on the graph on the left here, about a dozen countries represent 60% of the global burden. It really is a tragedy and a crime that we're in a world where we have such a relatively easy infection to treat, relatively easy to diagnose, and we have mothers going into A&C where they could be treated, where they could be tested for syphilis, and yet this is not happening, or largely not happening. And this graphic I've just put up now kind of shows that, where you have across a wide array of countries, a relatively high proportion of mothers who are attending ANC being tested for HIV. And this kind of highlights the success that the international community, the global health community, have achieved over the past couple of decades in trying to ensure that mothers who attend ANC, and also increasing, of course, ANC antenatal care visits in the first place, are being tested for HIV. We're also showing that there's a missed opportunity because a very low, relatively low proportion are also being tested for syphilis. To take somewhere like Uganda, for instance, more than 95% of women, the vast, virtually all women, are being tested for HIV, and yet only 43% are being tested for syphilis, 41% in Ethiopia, and so forth. And we're in a situation where this gap, this contrast between the progress of HIV and the limited progress against syphilis and the stillbirths that come out of this is, I think, alarming and also frustrating, because, I can move to the next slide, we have technologies in place which could easily address this. I've mentioned the treatment side already. A form of penicillin, which has been around for a long time, could easily treat these mothers. But the diagnostic side has been the stumbling point for so long. Traditionally, conventionally, we use lab-based tests. So the sample will be taken from the mother, taken to the lab, tested, brought back, then the mother would have to come back and be treated and so forth. By this time, you have a high degree of loss to follow up. Mothers simply are not coming back, or too much time has gone by, or there could be errors with the lab results and so forth. There are rapid tests. These are tests which I think, again, due to the recent COVID pandemic, we're far more familiar with today. Tests where samples are taken, and within, in this case, 20 to 25 minutes, you'd actually have a conclusive result in terms of knowing if a woman has syphilis or not. These are common for HIV, and the numbers I quoted earlier, showing the success in HIV testing during ANC, are all through to rapid diagnostic tests. What we have more recently, from the innovation side, are the development of dual HIV syphilis tests. These are tests that test for both HIV and syphilis at the same time. So if I can just jump back a slide, if I can, you have this golden opportunity to say, okay, all these mothers who are currently being tested for HIV, how do you also, by substituting out the test they're currently using and using these dual tests, suddenly you just have a leap forward, but all these mothers who would also be tested for syphilis at the same time, and then you ensure that treatment is available. Suddenly, all these stillbirths that are happening, all these congenital birth defects which are currently happening, could be almost alleviated. Certainly a huge step forward could be made, because the testing would happen and the treatment would happen. And yet these technologies are not currently available. This test is not largely available, and has not been for several years. And if you look at the different reasons for this, the large one is price. The test has been arguably unaffordable for some time. There are other barriers as well. And that's where CHAI is stepping in at the moment. That's where we're working at the moment. We are working with suppliers to reduce the price of these tests. And we've had success already. And I think there's more success that we will help to achieve. We are working at the country level to ensure these tests are made available, are substituted out for the previous tests that were in place. We ensure that our treatment is readily available, so that when a woman is given a positive syphilis test, that she's immediately treated and the birth defect, the stillbirth, is averted. We're ensuring that advocacy is in place to ensure that healthcare workers are aware of this and are trained to appropriately test and treat the mother. And we're working with donors, funders, and national governments to ensure that the funding is in place to support these tests and the treatments. This is the example of the access side, that bridging that gap that Professor Prashant highlighted earlier, about saying, how do you get these innovations to the market? How do you ensure that they're being used and scaled up in countries? And more importantly, how do you ensure that they're sustained, that there's funding in place from international donors, and this is obviously the preference, from national governments to support this in the future, long after CHAI has gone away. This is a good example of such a project. Q&A here. Fewer examples of projects that CHAI is also involved in, following a similar approach, similar model. And I'll pause here and happy to have questions later on. Thank you.
Thank you very much, Andrew. If you could just stop sharing your
Absolutely.
screen. Perfect, thank you. So yeah, no, thank you, the three of you. We're gonna now open the floor for questions. So if you could, I mean, if you have any questions, please just type it in the chat or raise your hand. While waiting for some of you to that, I think I can just get started. I think it was fascinating, just like listening to your three presentation, just like to see how big, your organization or your, goal was. So be it, Prashant objective of like touching 10 million life in 10 years, or WHO goal of, touching 3 billion people. And you've all had experience, of you just shown on, working on the ground with local communities. How easy it is to contact them, show the value of your program or technology, how easy it is to get their buy-in into what you are doing usually?
So should I respond to that?
Sure, yeah.
Very, very, very difficult. Health has never been on the political agenda. In fact, I believe that the whole society runs with politics and its agendas on what's important for people. And at least in the global South, health, except in a few countries, and I think I really respect Sri Lanka for being a leader in that, it has not been on the political agenda. So it's very difficult to get attention, retention orders from large scale buyers. It is much easier to sell for economic value. It is very difficult to get something out for societal value, if I could phrase it that way.
Okay, so you need to show basically the value of what you're bringing to them to convince them in the first place.
So the response to that is that showcasing value is not the difficult part. Actually materializing contracts, materializing a supply chain, materializing payments, and servicing at a scale is quite difficult, not only for young startups, but also for large medtech companies. And procurement is a massive problem in any sort of technology, and that has to be addressed somehow.
Andrew, how are you kind of like, because that supply chain problem Prashant just been mentioning, I guess that's something Chai had to deal with very often, right? How are you dealing with it?
Yeah, so I mean, first of all, as an organization, Chai is always working as a close and trusted partner with the Ministry of Health in the respective countries that we're operating. So when we're talking about, from a demand perspective, we're talking about going through the ministry, not separate, trying to set up parallel systems and so forth. Now, procurement, obviously is a huge issue. I think we'll find, where we have a product, a drug or some equipment that is the kind of the global gold standard, the WHO recommended device, where it's something that, again, if you went to hospital in London, you would expect to see, then there is no question from the Ministry of Health, any country, but no question of them being skeptical about its need. Of course they understand why they want that in their country. The question would be, can we afford it? How do we ensure that, even if it's donated to us in the form of, say, some equipment for a hospital, how do we ensure that it remains operational in the future, it's maintained and so forth? And those become the kind of the questions that come out here. So there's an access side in terms of actually the price, the procurement, how to actually afford that. And there are, depending on what we're talking about here, there are donor agencies that can support that. But there's also a need to ensure that the country themselves, the government themselves, are able to build this into their budget line going forward and support the future procurement or maintenance of these products in the future. That takes work. That takes work not just in the Ministry of Health themselves, but them to then justify this to their Ministry of Finance colleagues and so forth. That political kind of the sausage making, as it were, is hard. That's something that again, as an organisation like Chai, we can help in the sense of helping to make the case for this, We can bring data, and we can actually increase the transparency in the market, so it's better understood how this product would be used, how to make it more affordable, what the economic case would be. We can help support on the ground pilots to show the impact of this work if a new product was being rolled out and so forth. There are elements here. Fundamentally, it's down to the ministry themselves. We're providing the ammunition for this. We're helping to ease this path. But there is that question about how do they, how is that political buy-in there? Is that political support for such a product available or not?
Okay, thank you very much. Mustafa, you have your raised hand. You want to ask a question?
Absolutely. Thank you, Simon. Thank you to the Tribe team for the incredible presentation today. Andrew, you might recall that we met briefly actually last year when you came to LBS to speak, and I recall you speaking on similar topics around dual HIV syphilis testing. So great to hear you expand on that as well. Actually, my question is very timely because you were just talking a bit about it just now on sustainable health financing. I know that Tribe does a lot of work both with corralling funds through donors, as well as setting up ministries of health and governments to be sustainable in their own financing. I guess I wanted to peel back the onion there. Maybe you could talk about some bright spots that you've seen where countries have transitioned from foreign aid to a higher percentage of domestically sourced funds, and kind of some learnings that you might have had from there. What's kind of important beyond the business case? How do you tactically make this happen on the ground? Thank you.
Sure, absolutely. Let me do it using an example of one of the subjects I presented on earlier. So testing of HIV and syphilis testing in ANC. And I'll do that using the example of Kenya, the country Kenya. This is a country that for the longest time received funds from two agencies, the Global Fund and PEPFAR, and US government, to procure rapid tests during pregnancy, during ANC. So these tests I spoke about earlier, and the success that Kenya in particular has had in testing pregnant mothers for HIV during ANC, the money came from these two agencies. Now, increasingly, the government of Kenya is transitioning away from that. There are various reasons for that, but one of the key ones is, the government is now prioritizing, well, not just prioritizing this, that's always there, but actually able to actually say, let's ring fence the funds to support the procurement directly ourselves. And so we are seeing already that there are now tests that are being procured by the government. These are now dual tests, because again, the economic case has been made. There isn't very clear cost benefit analysis in place saying, okay, by procuring the dual tests, especially at the lower prices that are now becoming available, even at the higher prices, to be honest, but especially at the lower prices, we are actually, as a government, saving money, and obviously averting deaths, most importantly. And we are willing to assign a proportion of our national spending towards the procurement of these tests. And I think I believe the intent is that over time that transition will continue, and so we'll get to a point. I'm not sure exactly. I should know this, but I'm not sure exactly when the Global Fund and PEPFAR funding for these tests will end in Kenya. I don't think it's in the relatively near future, I think. And we're in a situation where these will be entirely procured using national funds, and that's the ambition and aim, of course, in all countries. But here we actually have tangible proof of it happening. We could apply the same principle, the same approach in other countries as well, especially in West Africa, where it's also occurring. So, Mustafa, that process is happening. It's happening with help and assistance, but there is a natural transition there away from just donor funding, more to the government's controlled, government's own funds.
Thank you, Andrew.
Thank you. We also have a question from Christine, who'd like to hear your thought on how business and ed play a role in improving access to quality care in emerging markets, and how this could evolve in the future, and if what would be, according to you, the most sustainable solution. Which one of you want to take this one?
Well, although I have no expertise, I can start maybe, because there's a profound discussion taking place in the world about how health is financed, you know, and just to build on the previous one as well. Many low and middle income countries have got into the habit of not looking for internal resources as well. So you know, in a way, we have aid dependency, and now we're trying to become independent of aid. So it's really quite a shift. As was said earlier, I think Prashant said, I mean, primarily decisions are political, and particularly in many countries, political means an outlook of 2 to 3 to 4 to 5 years. So, you know, it's very difficult to have long-term system strengthening. So I have no expertise in products themselves, but the systems we need to identify what's required, to source it, to deliver it. These are all evolving at the moment. So for example, during COVID, my organization, which really wasn't operational in this sense before, we didn't work so much in supply, we moved about $1 billion worth of supplies to 184 countries with partners. Now, what does this show? That shows there's a big unmet need out there, right? And unfortunately, much of aid is linked to foreign policy of the country giving the aid. This is true. Some countries actually come out and say it. Our aid will further our trade agenda or our national security agenda. So I think, you know, nobody has an answer, but these are things we shouldn't be naive about, how difficult these systems are to change, because they are linked to much bigger perceived needs. Now, even let me go back to the example of Sri Lanka. We say health is free, and the government supposedly gives it for free. But about 50% of the health services are offered by private sector. People have a choice. So, you know, there is no country where private sector, civil society, donors don't play a role. I think the conversation has to shift to how can countries become more strategic about using all of these sectors in a fair way. This is the issue. So again, it's not about it's not about I'm not against selling something, but it has to be done in a fair way, and we have to figure out how can people who can't afford product services at the point of access, how can we support them? That's what universal health coverage is about. It isn't to say you can't have private sector, you can't sell things. The other complication, I think, just to add to the discussion, is when we're going with, we live in an era, we are living in the fourth industrial revolution, right? Where there's so much biotech happening, so much information technology, and innovation is really fast. But we work in these very solid frameworks. You know, the government buys this product from this place and it moves it slowly. It accepts that it loses a lot by the time it gets to the periphery. I mean, I've worked in countries where, you know, the government truck is full of medicines. By the time it gets to the hospital, half of it is gone, right? So all of these systems, and a lot of people benefiting from this system. So unless, I think the pandemic has shown, unless we really take a different approach to financing, the balance between private and public, national and international, and also the new dimension from national to local level. So a country may have all its supply in the big cities, but where it's most needed, it may not be get there. So there is actually a big debate. And this is the kind of thing actually the G20 and others are talking about as well. So no answer, but just sharing some thoughts.
I could weigh in on the technology development side, and I firmly believe that aid is a catalyst till you become self-sustaining, and you cannot depend on aid forever because other forms of imperialisms will evolve, and that happens, number one. Number two is a lot of aid in kind is quite surprisingly not contextualized. I mean, if you take a trip to parts of the global south in America and in Africa and Asia, you'll be surprised that some foundation gifts a few scanners and it lies in hospitals, was never plugged in. And even if it is plugged in, there's no one who knows how to use it. A case in point, we were trying to coordinate shipment of some ventilators in Mumbai early on. And there's not an anesthetist. So you can't expect a nurse to do invasive ventilation because it's as good as killing someone. If you put a ventilator in inexperienced hands, the person is going to die. So contextualization of products can only come from within, because sitting in London or sitting in New York cannot give you an insight of what is happening 100 kilometers away from the capital city of a country. And it is true for everywhere. So it has to be contextualized. That's point number 2. And my last and third point is aid is an instrument of not only humanity and humility, but as my colleague just said, Dr. Gaya just said, it has a lot of other political implications. Aid always comes at a price. It's never free. Aid is never free. It is supposed to win political currency. It is supposed to win favors. It is supposed to win some strategic interests. And it cannot be forever. That is my take on this. It has to enable, and in my personal opinion on that, is that a collective channel through a global respected agency has a much higher chance of change than through an individual or a single government, because then it diffuses those interests and brings in more science in where to put aid and for what. Maybe this is quite controversial, but I thought I'd say it.
Sam, one thing I forgot to say is, we have this concept of solutions being developed in the global north and marketed and sold to the global south. I mean, innovation should take place where the problem is, and there's a big global youth movement that is really riding this wave and saying no. And we need to work on our own solutions. So for example, during COVID, there's a whole solidarity, there's been a small grants to youth across the world to find solutions to urgent problems they have related to the pandemic, and not just medical solutions, social solutions, labor solutions, and so on. So I think we should also, and we have the same thing in public health and medicine, where most of the research is done in certain countries by a certain context. And then we have the challenge of taking it and shaping it and selling it and adapting it. But we have to encourage R&D everywhere, right? And of course, you don't get great commissions for importing ventilators if you do that in your own country, I agree. So some people will be very unhappy, but this is really the solution, that people have agency, communities have agency, and we have to support that system, not necessarily to give them the product, right? And products can be shared, moved, sold, marketed in every direction, not just from capitals to periphery, not just from high income to low income countries. So I think there's a political movement around that as well.
Perhaps I could jump in. I mean, everyone on the call here are business students, and and one of the basic things you're learning, of course, is about listening to the market, responding to the market, and the same is true in global health. We have to be in a situation where we are taking bottom-up approaches, where we're going to the community. So yeah, I focus on maternal neonatal health. In that sense, you have countries, parts of northern Nigeria, for instance, where something like 80% of mothers are giving birth outside health facilities. They're giving birth at home or in their local village, often usually with no skilled birth attendants nearby. And so, of course, if they develop birth complications, there's a lot of issues that come out of that. And so when you try to understand why this is, well, when you try and fix this issue, when you try to work with the government to try and address this issue, it's no use me sitting in London or going to government offices and sitting in Abuja and saying, hey, let's work on new policies. That makes no sense. You have to actually be talking to these mothers and to the wider community and understanding what their barriers to access are. What's the reasons why they can't or will not go to the health facility to give birth, or if they start developing complications during pregnancy, going to a tertiary level, hospital level care. What is happening here? And it's only when you start understanding those issues that you really start working with the government to try to address them. And there's a role for business there, and when you start going to more isolated communities, health facilities themselves may not be that accessible, but the private sector often will find a way. You can go, if you have your malaria, or if a newborn child has severe diarrhea, you can go to your local health kiosk, just a shack where they're selling the basic commodities you need. And again, the private sector is addressing that market. Same is true for contraception. But you can also ensure you can work with the private sector to ensure that they are selling the optimal drugs, the optimal commodities. There are things there you can do which are, again, sustainable. Private sector is still making a profit and staying in business, but also optimal in terms of serving the needs of the market, the mother, patient, or whoever it is. So I think that there is kind of there's a mindset there, which Dr. Gaya was highlighting there, about working, really understanding the users, understanding the patients, and addressing through them, working through the ministries of health to do so. That is the way forward, rather than being sat in the global north and just brainstorming strategies. That is not a solution, and shouldn't be on anyone's radar.
Thank you very much, all of you, for sharing your insight. Your insight was really fascinating to hear about. All the real world example you guys have encountered throughout your career. So we have about 15 minutes left before the end of the seminar. So I'm gonna shortly create breakout rooms where the audience will be able to interact directly with you. Just before doing that, I can just quickly advertise the next session for our global track, which is this Thursday. This time the seminar will be on digital health for community impact around the world, where we will hear from two real-world examples. The first one will be from Dr. Hifat Zaha, who's working for Sehat Kahani. So that company enabled married female doctors to work from home in Pakistan, thereby addressing healthcare professional shortage and the doctor bride problem in Pakistan. And Dr. Mohamed Abourawi, who's the founder of SPITA, which tackle the brain drain phenomena and links underserved patients in Africa and the Middle East to a global pool of cultural and language match specialists. So this is this Thursday. I'm just dropping in the chat the link if some of you want to register. All right, so I'm quickly going to open up the breakout room. I'm just going to rename them. So the first one, there will be Prashant. The second one, there will be Gaya. And the last one, there will be Andrew. I don't know if I can assign quickly. Yes. So where is Prashant? Prashant is here. Assign Gaya, and the last one, assign Andrew. All right. So if you could, so those of you who've been assigned back at room, if you could get there, and the other people in the audience, if you want to interact directly with all speakers, please just go into these breakout rooms and have a chat with them.